I appreciate you watching this video. I did not record my introduction on the day of the in-service, so we're kind of doing it after the fact. I just kind of wanted to give you a brief overview of why we did the in-service and what you're about to see. So, as you know, our volume of Dr. Hosford's patients has increased, and I think there's been a lot of unrest and a little bit of uncertainty about their needs and the complication of taking care of them. And then, of course, just with Dr. Hosford herself, there's been concern about her attentiveness to the patient's pain, whether or not you can reach her, or when you do reach her, is it a good experience or not. So a few weeks ago, I met with Dr. Hosford and Dr. Reagan. Dr. Reagan is the Chief Medical Officer for the hospital, and Dr. Yeomans. And so in the course of that conversation, we just had some really good communication about her expectations for the patients that she admits to the hospital, and you know, kind of what our role needs to be in that. Dr. Hosford expressed to me that she really doesn't admit patients to the hospital unless they absolutely have to be there. She likes to treat them at home, and so the patients that we have in the hospital are going to be more sick. So what we want to do is equip you with the tools and the things that you need to take care of those patients without without having so many questions, and might make that whole process a little bit more streamlined and where it's not quite so time consuming. So a few of the issues that have kind of continued to come up with her patients are accessing their ports. The patients typically come to the hospital and say they don't want, you know, don't touch my port, no one's supposed to access my port. And they're taught that because they don't want anybody accessing their port unless that person has been trained. So we do want you to feel comfortable accessing ports. And so in this in-service that you'll see, Veja Craddock, who is the patient care coordinator for the Southwest Cancer Center, is going to walk through and show you how to access and de-access those ports. Another skill that comes up occasionally is when a patient's PICC line has gotten clotted off, and there is a TPA protocol that is very step-by-step. It's got pictures, it's very thorough, but Allison is going to walk you through how to follow that TPA protocol to flush out those ports. We'll continue to have more oncology in-services as we go along. We want to equip you with things to help you feel more comfortable taking care of these patients. Dr. Hosford also gives a pretty just personal talk about gen oncology and her expectations, and I hope that after watching this in-service that you will feel more comfortable approaching her, that you see that she does want to communicate with us. And so I just ask that you bring any questions or concerns you have to me or directly to Dr. Hosford. Also, if you have anything that you'd like to be in-serviced on, please let Allison know and we'll get the education out to you. All right, enjoy.
Best side.
It ain't my butt. Okay, so let's see. I've met most of you. There are probably some people that don't know me because I'm at odd hours. So I'm Sarah Hosford. I'm the G1 oncologist, and I will be celebrating Labor Day weekend, my second year here. I started September 6, 2013. And what I thought I would do, actually, well, I didn't plan much ahead, tell you a little bit about me, where I came from, how I surfaced here, and tell you a little bit about G1 Oncology, how it started and why it is the way it is in terms of the specialty, and then open it up to questions. I'm happy to air issues that people felt. You know, I know what we met a lot and talked about how things have gone, and see how we can work together, because I do think and feel very strongly, since my home is OBGYN, and this is OBGYN's home, that it will work best for us to have patients on our unit, because it just will work best. Like I can tell you for various reasons. So let me tell you a bit about myself. I'm 56 years old, I think. I'll be 57 in November, I have to add. I grew up in Dallas. My dad was an internist at Baylor Hospital from 1963 to 2005 or something, for a million years. And my mom was a preschool teacher, and I'm the oldest of three girls. And we all grew up in Dallas and went to high school there. And as that was going along, I decided I liked medicine. I actually wanted to be a veterinarian first. And I remember helping my cat deliver her babies in my closet and watching her eat the placenta, and I thought that was all awesome. So I must have had OBGYN somewhere in my history, and that's funny because I hadn't thought about that much. Then a couple years ago I thought, oh my God, I remember that story. And that's back in the days when you didn't neuter cats and you had babies and, ridiculously amount of kittens. But I thought I wanted to go into internal medicine, and so I went to college in California and kind of planned on going to med school. It's a long road. It's a long, hard road, and I'm not sure I'd do it again, but it's a lot of learning. But still liked going into medicine. If something else came up, I'd do that, but I just thought that sounded good. My father was an awesome role model. He was a kind of an old-timey physician. His patients loved him. He would take calls from them anytime. He would go see them at home. He was just the kind of physician I wanted to emulate. And so a lot of the things that I do, he probably wasn't as intense, but a lot of things I do came from my modeling after my dad. And of course my mother was an awesome woman, and I learned a lot about kids and raising people and being a mom and things that have also blend over into what I do as well. So I finished college and applied to med school. I went to UT Houston in Houston from 81 to 85, a million years ago. And during my medical school training early on, I really started liking women's health care. I don't remember knowing about it, except I really liked it. I was a model for medical students to learn how to do pelvic exams, and you have to really love it to let them do a pelvic exam on you when they're so panicked they can hardly stand it. And I thought, boy, this is interesting, and I can take power of my own body. I can understand how I can make it easier for me to have an exam, which was an interesting part that came out of it. And I said, I really like women's health care. I thought baby delivering was fine, but that was never the thing I gravitated to as much as GYN and pregnancy prevention and contraception and all that stuff. And one of the things that in Houston, one of our main teaching hospitals is MD Anderson, which of course is a world-renowned cancer center. It's become more so. And we did rotations of all of our third year, all the medical students you see are third years. We did rotations at MD Anderson for almost all of our core rotations: psychiatry, pediatrics, OBGYN, surgery, and medicine. And I think I did a rotation of every one of those at MD Anderson. And contrary to what most people find, which is they don't like cancer patients, they think of them as horribly depressing and dying, I really liked it. And I thought, oh, this is strange. Obviously, I like this stuff. And so I said, well, I guess I just do what I want to do and what it feels nice to me and rewarding. So I said, well, I'll just keep thinking about cancer, and if I like OBGYN and there happens to be a specialty with cancer, if I still like it, then if I get into residency where I see the real life of it, if I still like it, I guess I should do that. And so I kind of followed along that path and did my residency in Dallas at Parkland, which is, we delivered 15,000 babies a year. I had done 3,000 vaginal deliveries by the time I finished. I mean, it was just like ridiculously busy. But I really liked cancer care, and I really liked the complicated patients, and I think it combines a little bit of what my dad did, internal medicine and kind of adult care, with OBGYN and GYN stuff, and so it just kind of kept fitting. So I said, well, I guess I'm supposed to do this. And GYN oncology as a specialty is a subspecialty of OBGYN, like Dr. Yeomans is a maternal fetal medicine and Dr. Fian Wong, a reproductive. We're the third standard arm of OBGYN, and it's a required part of residency training to, I think I hung up on her. Oops, she's probably listening to my speech. It's a required part of the training program to have a GYN oncologist. So for the longest time, because there wasn't somebody here, they had to use doctors at Covenant, but they really needed somebody on site all the time, and that's why y'all are seeing an increase, is that you have somebody here who's full-time. And part of our mission in GYN oncology is also to train OBGYN physicians to be more comprehensive physicians, to be better pelvic surgeons, to be able to handle complicated things different than obstetrics, and to manage and be able to identify women with cancer and how they present and how to get them through the system to a place where they can get cared for. So it's a very competitive field, and there's probably about 40 or 50 people a year in the United States trained in GYN oncology. So if you look at the numbers, that's quite few, and it's very competitive now. It's become, I'm not sure at this point I'd still be able to get into it because it's very, very competitive and really complicated, well-trained people apply for it. And so it's a difficult field to go into, and so you've got to be, want it really badly and try really hard. And it took me 2 tries to get into oncology, actually. I didn't match the first time, and that year between my residency and when I was starting my cancer training, I went to Atlanta and was working with the G1 oncologist there. And of course, like everything, that's a life-altering thing because that's where I met my husband. And so after I then was, second try, trying to get into a hard program, and I'm sure you guys have experienced getting into nursing school and things where you have to try hard, and sometimes you don't get the first time, and you have to really try hard and want it. And so that's a lot of the reason I still put a lot of, verve into it, if that's a nice way to say it, because it was a thing I wanted bad, and I worked really hard, and to this day, the most exciting moment of my life has been when I was accepted into an oncology fellowship. But I hate to tell my children and my husband that, because it's supposed to be the birth of your first child and your marriage, but that was still the most exciting thing I had worked so hard for myself. And so I met my husband in Atlanta. I was working there in 1989, and then tootled off to Rochester, New York to do 2 years of oncology training, which is, a fellowship in G1 oncology. And we hung together, and then I went back to Atlanta and spent the next 21 years in Atlanta at a community teaching hospital that's not like this, but it had an OB/GYN residency, because the other thing I found as I went through is I love teaching. And you have to like it and be good at it, because my philosophy is that if you don't train students and physicians, like the residents, to be good doctors, then they walk out and they hang their shingle up and nobody knows if they're good or not. Patients can't really tell unless you do something really badly. So my mission has always been pretty much half and half about patient care and education. And teaching residents is hard. It requires a lot more time than not teaching people. It requires working with people that are awesome and people who need a lot of help. It requires patience, which I have sometimes and not other times. The students are kind of there just to watch. But the residents work with me to learn how to be good doctors, so when they walk out the first day after their 4th year graduation, they can take care of somebody complicated or know how to call for help and get something done. So there's a lot of what I do that involves making sure they are learning how to get something done, supporting them but not doing everything, because I can do it all myself, but that doesn't help them become good doctors. And all of us are in that mission when you're in a teaching environment, because you struggle, good and bad, but you aren't born knowing how to be a good doctor, so you have to have teachers, just like we all had a kindergarten teacher that started us on our way, or all the teachers along our path, is that you've got to have somebody who cares about you and wants you to be better, pushes you and works hard with you to teach you the right thing. And that's all involved in what we do here. You can't separate one from the other. It's everywhere. It takes more time. It's more rewarding. And it makes us proud to put out doctors who can take good care of people, because it might be you or your mom. You never know. So I had been in private practice in Atlanta for a long time. My hospital lost its residency accreditation in 2008, so I stopped having residents all the time. I worked with Morehouse School of Medicine residents for a while, and I need to turn off my cell phone, I'm so sorry. So I kind of lost the teaching part of it, and private practice was difficult to be in, and my hospital didn't really value cancer care. I didn't really have a good program. It was hard to get chemo for people, and I was piecing together this practice, and there were enough G1 oncologists in Atlanta, so I thought, well, maybe when my kids are getting ready to finish high school, I should try something different. And it turns out there's tons of G1 oncology positions for places like this that need somebody good. It's a smaller number, smaller city, but they need somebody to really do the right thing. And so I happen to have known Dr. Yeomans from when I was in residency. He was a maternal fetal fellow for the first 2 years of my residency, and I knew he was an awesome guy. I knew he was an awesome clinician, and that he had the same kind of concept about teaching and really doing a professional job. And so when I heard about this job being available, and I was from Dallas, I thought, well, that might mix up. And so I came out here, and I just knew it was the right job for me. Part of what happens is that when you're in one place for forever, people get really used to you. And so people at my hospital, the people who loved me, and people who didn't love me just learned how to find something else to do. So I kind of had gotten into a place where the people that knew me, knew what I did, knew how my approach was, we got along really well, and it's interesting when you go to a new place, you have to start from scratch. And so I think I'm kind of who I am. I don't know, the older people in the audience know you are who you are at 57, and it's hard to change. But I think coming to a newer place, I've had to try to reestablish, this is how I believe in things, this is what I do, how can I compromise, and how can I create the thing that I know is going to work right, but it just takes a little time getting there. And so that's how I came to Texas. I'm very happy here. The first year I lived here, my family still was in Atlanta, so I was traveling back and forth. It was very difficult, and my husband now is here because my youngest son is now in college, starting last year, so, or starting this past fall. So, I had a struggle, and it was actually very hard to live in two places, and I didn't feel like I belonged anywhere, and I didn't feel like I could please anybody, because people in Atlanta needed me, and I was in Texas. People in Texas needed me, I was in Atlanta. And so it was complicated, and so it's a bumpy start. But I think that I have started to see the fruits of having a G1 oncologist here. The reason we're all struggling with this is we're growing. We've got sicker patients. People are now being sent here who either didn't get care, or went to doctors who weren't qualified, or went to other places that were too busy, or had to travel to Dallas, or had to travel to Houston. So now we can provide that kind of care where people don't have to go far away. They might have to come in from outskirts to Lubbock, but they don't have to travel hundreds of miles, which is even more stressful when you're dealing with a significant illness. The residents are smarter. I don't know if you ought to look at the difference between the chief residents now, Dr. Khalid and Dr. Manaz and Dr. Kulkarni, because you probably, if you knew them younger, can tell that they hopefully have learned more, they're more competent physicians, they get a better sense of complicated patients, and that's the fruits of all of our labor in teaching those people, because that's about half of our mission, my mission here, is to see cancer patients but teach. And so I think that I see that those girls have really improved, and I'm working on the third years, we're getting there, and that's the kind of thing we should be proud of, is to see that mission go on. Let me tell you what stuff I'm responsible for. G1 oncologist is a very comprehensive specialty. We see all of our own new patients in office, and we operate on all of them. I give all of my own chemotherapy. I don't give it myself, but I orchestrate it, I write the orders, and I work very closely with a radiation oncologist. So it's a different subspecialty than almost anywhere else. People who have breast cancer go to the breast surgeon first, they get their surgery, then they go to a different person to take care of the radiation if they need it, they go to a different person to take care of the chemotherapy or whatever. G1 oncology developed as a specialty in 1969, it was founded, so it's not that old, as a comprehensive specialist who if I could manage everything myself, I'm sure I would. So I'm involved in every aspect of the care of my patients, and I follow them for the rest of their lives. So the intensity is a little bit more because it is structurally a specialty that's developed and was founded by men who believed in that kind of comprehensive care for women and saw that it was not being met, it was being put together piecemeal, a general surgeon and maybe an OBGYN and maybe this person. They said, we can do better, so we can make it where one person is responsible for everything. It requires a lot more organization, there's a lot more detail stuff, and it's not just anybody's cut out to do it, because I think if you do it right, you have to be a relatively intense person or it just doesn't work. So that's the kind of stuff I'm doing, and when I'm in the clinic and with Veja, I'm seeing patients, I'm writing chemo orders, I'm checking labs, taking care of a complication, radiation if I have to go over, and when I'm in the OR, I'm doing ovarian cancer surgeries and taking out bowel and doing bowel resections, and that's just what we're trained. So it's a complicated set of things, and so on days when I'm in one place, I'm hard to reach for the others, and vice versa. And that's also why the residents are a very important part of the connection, both for them to learn and to get stuff from me when I'm not necessarily available. So G1 oncologists have a pretty comprehensive, complicated, plate of things we have to do. And I take all of that very seriously. So I begin to see that we're really growing, and I think we're going to get more patients. We get underserved women. We get women who don't have health insurance. We get women whose cancers have progressed because they and their environment have not made it easy for them to get care. A lot of women have been in denial for a long time and come in with horrible cancers. The two young women that we've lost recently were both 20-year-old women who could have had their life saved if they came in earlier. We can save their life by giving that HPV vaccination, and I'd love for y'all to be advocates for that. Because anytime I see a patient with cervix cancer, I say, has your granddaughter been vaccinated? And we won't go into a conversation about prevention, which is phenomenal that we have a way to prevent cervix cancer. So we deal with people whose lives are not perfectly, you know, they don't go to the doctor every year and get their pap smear and get their mammogram. They mostly are the people who are underserved for a variety of reasons. A lot of them come in uninsured, and we struggle with how do we get insurance, how do we get the social worker, so it's really a group thing. Invasion, we struggle with this all the time in the cancer center. But this hospital says yes to patients like that. They work with them financially, and I haven't really had to turn away anybody. Doesn't mean it's easy, but it happens. So all of those things go into why everything is complicated and stressful and frustrating and stuff. Because when you come in really, really sick, you have to undo all those components that have gone into that complicated patient. And the people in the hospital are the most sick of those, because otherwise they wouldn't be in the hospital, which is what also means it's complicated. We have post-op patients, but the people who are hard are the people who come in with lots of things going on, and we all need to band together to really help them, because that's the kind of stuff we're going to get. We'll eventually get the nice, healthy, insured person, but we're going to get the you know, under-met needs, and there's a lot of them coming from New Mexico. I went on a marketing trip Tuesday to Carlsbad and met a group of doctors who was real happy. They had no idea I was here, and they were real happy. They sent a lot of their OBs, but they were happy to know there was somebody else, because they struggled where to send their patients. They were sending them to Albuquerque, and Carlsbad's a lot closer than Albuquerque. So that's the kind of stuff that I do, that I'm responsible for. I certainly know that I'm an intense person. I am what I am, but I expect, if you all call me, that I will be helpful, compassionate. I'm very easy to reach. I'm textable and phone callable anytime. I take my phone with me when I go on trips. I'm a little obsessive about all that. So even if it seems scary to call me, if you call and say we're having trouble, I will be on your side 100% of the time. And you have to just get over being scared of me, because what happens is, like my mom said, my bark is incredibly worse than my bite, because I care about patients. I care about that they get the right care, and that involves all of us banding together and working through complicated situations that may not be in your comfort zone. I'm boarded in palliative care medicine and hospice, because I added that on a couple years ago by taking an exam. So I have not as expert an experience as the palliative care team, but I do have a lot of experience, because for 22 years I've dealt with people who die from their cancer, so we kind of by default do that. So there's a lot of things I think we can learn from each other, and you know, I commit to trying to be less intimidating sometimes, but you really just have to blast past that and know that I care about it. And if we're all out there for the patient concerned, we will never have a trouble working together. So how's that for a speech?
I think a couple of things that she said that I think were kind of important to understand for us on our side is knowing the difference about caring for all aspects of patient care, where we're kind of used to doctors, you know, consulting out for different things. That you know she provides the comprehensive care, but then also I think sometimes knowing that each step of that cancer treatment, that she's been at every step with that patient, and that was kind of something that I took away from the first conversation we had was, you know, at times we wonder, but do they understand what the patient looks like right now? Like, is this, you know, what about right now? And one of the things that Dr. Hosford said to me about a particular patient incident that we had was, she said, I know this patient very well. I know what she looked like yesterday. I've seen her throughout her course. I know, and just to know that how well and deeply she knows her patients because of how much you've been through with them in each step of their process, I thought was really just enlightening. What questions do y'all have? And, you know, use this time for questions that you have about her or care or patients, or I know it's difficult sometimes to organize it all, but we...
Yes.
My question is just, I'm close to cancer patients because I lost my mom with cancer. It's just not the kind of cancer that you care for. But in all cancer patients that we deal with, their main problem usually is information about their care and pain relief. So what is your, because I noticed with the patients that I cared for, their pain usually is not, pain reliever is not enough for them. So I just would like to know your protocol with pain relief.
Well, there's not really protocol. First of all, if you guys want to know what's happened with one of my patients, if you go to my admission note or my most recent clinic note, the first part of each note is a summary of their treatment, what they started with, and it's kind of like an additive field. So if you want to know kind of what things have started and been through, you'll be able to get a glimpse of that. I am very talkative with patients about what their cancer is, what I want for their treatment, how things are going. Whether they hear that or not is another story completely. And there's always sometimes a balance, particularly people who come in really sick. A lot of times we're putting out fires for a while and we don't know or can't tell them prognosis. And a lot of times you don't know prognosis. So what their understanding of their treatment and stuff, we certainly have offered, and I talk to my patients every time they come to the clinic, I see them. And you know, so we go over what's happening, we talk about the next step, but that between what I say and what they hear is a challenge, because I find that even though I've said things before, people don't hear it. There is no particular pain control issue or pain protocol. Pain is an expression of multiple things. It's an expression of anxiety sometimes. It's really an expression of cancer activity. It's an expression of using narcotics or drugs at home. There's a lot of intersections. And it also depends on the age of the patient and what, you know, older patients, you have to be much more careful about narcotics. So it's a work in progress. There are also times when I'm figuring out if somebody's mental status is stable that I can't give them a lot of heavy narcotics. And so there's lots of things that are ongoing. So I never want somebody to be in pain. Sometimes it's harder to fix it than others. And I almost always have been working on it as an outpatient. And remember, the person you're seeing in the hospital is going to be the most acute. So it's not like they've been hurting for months, they walk in and I say no. I've been usually dealing with a lot of different pain, and I try to put that in my notes, although it's probably not quite as well represented. And it's usually an ongoing issue that's not just this moment. Certainly post-operatively, pain is going to be a different issue than chronic pain. A lot of my patients, I find, have chronic pain, and the cervix cancer patients bring this out most everywhere because they're often have had pain for a long time before they ever dealt with it. A lot of times they are girls who've used drugs and alcohol, and that's all intermixed with it. And they're usually people that cope poorly with what's going on, or they wouldn't really be in that situation in the beginning. Narcotic abuse is rampant. The whole deal with the hydrocodone and the triplicates is that people have used narcotics like water, and I have become very stingy about narcotics because they're dangerous. But yet I am willing to give them liberally if I think the situation is one that we really need pain control. I'm a big advocate of longer acting stuff, Duragesic patches, but that all has to come with time. But yet I'm never wanting someone to be in pain that we can't address it in a safe way. And that's where the intersection with the residents come. I think for y'all around with me when we talk to patients, it helps you know what other things are in the back of my head, which is usually several weeks or months of stuff before and where I'm going after, and this is just one moment. But you know, we've become very, very focused on the pain in medicine. I think that's probably been a little more that you guys are after the pain 1 to 10 and stuff, but it's become almost its own focus rather than stepping back and understanding where is this pain expression in the spectrum of what the patient's experiencing, because there's a lot of other factors that go into pain. And usually I've seen these people in the clinic and I have a lot better understanding of depression and all kinds of things that go on. And so I try not to just throw narcotics at people without looking at the whole spectrum. And that's the kind of stuff that you guys won't understand as well as I do, because, you know, like Jill said, it's a longitudinal thing, and I've been dealing with it a lot in the office because almost all of these girls are in the office regularly getting treatment, getting radiation, getting chemotherapy. The post-op patients are usually not the problem. That's an acute event. It gets better in a day or two in their home. But that's where we should work together and talk and say, well, it looks to me like she's in pain. Why aren't you giving her something? And me or my resident will be very happy to explain, what's going on, and whether or not patients hear us or understand it is the whole other part of it. But I think there's a lot of potential for us to really work together on stuff like that. So you understand what I'm thinking. You can help me be my eyes and ears, and we can arrive at the right thing. So, yes, Paige.
We're used to this issue of pain, and Dr. Hosford is truthful when she's saying that for even the medical oncologist, it's been difficult to really know who's in pain and who isn't, because there's a history usually behind it. But one thing that's really important to know, and I hope that at some point y'all will really make the effort to go to a palliative care talk, or even if it's just an hour, some sort of presentation, because what we have found is, for the most part, these people that are complaining of pain, it's usually, like she said, something underlying. It's a spiritual pain, it's an emotional pain. It's usually something else other than the actual pain itself. And so it just manifests itself through the patient saying, I'm in pain. So we've had multiple people. I can think of one who really, when it came down to it, what the patient really needed was for someone to read Bible verses to her, because that's what she was accustomed to. And she was experiencing spiritual pain because she didn't have the same involvement in her church family as she had before. And so once that was addressed, it was interesting. The pain went away. But even the family was like, we need to give her something else, we need to give her something else. So that was one thing I wanted to mention. And the other thing I wanted to mention is when I met Dr. Hosford, I loved her to death. And then a couple of weeks after we worked together, I thought, wow, she's kind of gruff. But you know what I found out? If you will ask her, she will always give you a good, truthful explanation. And so now I just always ask her, she asks me, and we communicate, I think, pretty well.
Yeah.
That wasn't very convincing.
No, and the thing is, communication's hard. We tend to get around it. We tend to text and email and avoid and ask somebody else to do something. And our society in general is getting away from direct communication. I'm the person that deals so much better with direct communication. And if you just tell me what happened, tell me the truth, say what you need, it'll all be so much more profitable for all of us. And
the other thing the one other thing I was going to mention is I feel badly for you guys, because I know that y'all deal in happy, happy events every day. Birthing, babies is most of the time, I'd say 99% of the time, it's probably a happy end result. And so I feel badly for y'all, because from where we come from, and she actually took the words right out of my mouth, what I have always said, people are always, how do you do that? How do you deal with those kind of patients? And, someone has to do it. Mm-hmm. Someone has to help the people who are dying, just as those who birthed the babies. And so I feel like that's what I was called to do. I love the patients who are dying just as much as I love the ones who have a good outcome. And over time, I just know that's what I'm supposed to do. So, I think coming from you guys, where you guys are, if any of you just even want to talk to someone, any nurse in the cancer center, we don't have a very high turnover at all, because usually people who know where they belong, right? And so please feel free to ask and come over.
I'm sorry, what's your name?
Oh, Vasia.
Vasia Pratt.
Asia with a V. So, but there's plenty of people. Y'all might know Willa in chemotherapy. She's been there many, many years. Lori, Dr. Hosford's nurse, has been at the hospital.
she knows everybody. Years. She's been here and worked for everybody.
I mean, a total one time we figured up the experience in chemotherapy. We now just got an 8th nurse because, as Dr. Hosford mentioned, the volume of GYN patients has really increased volume in both chemo and radiation. And so we just hired our 8th nurse. But out of those 8 nurses, they have a combination of experience of like 270 years. So we're not talking about people who just, you know, just decided that they wanted to go into oncology. They've been there, they've done it, and I want to be able to lend a hand to help you guys as much as possible. And that's one of the things I'm going to help you with as well here in just a moment is access and ports. But know that when we get to that, you guys can come to the Cancer Center. If you have an hour, come over there. I bet you can get 10 ports in 1 hour. I'm not kidding. We have so many. And I want y'all to feel comfortable with what you're having to do. And so, I don't know, that was kind of my spiel.
How many of you have been through the Cancer Center, have toured through and seen it? Been over there? I think that to some extent, just walking through there, I mean, I'd love for you to go and spend an hour with Veja. And we talked about in an email that anybody who wants to do that, to get a little bit more familiarity and comfort with those things, will add it to your schedule. But I do think that sometimes even just walking through there and seeing, you know, it changed. I guess what it did for me is it helped me with scope. You know, when we see it so rarely, that in my mind, you can almost get to that defensive nature with the patients, like how can this be not addressed immediately, or how could this particular pain thing not, like, why don't we just give her whatever? I mean, she's hurting. It doesn't matter. Let's give it to her. She's in stage 4, you know. But when you see the vast number of patients being treated in the Cancer Center, and you see that scope, I think it really kind of changes your mind about some of that. And one of the things that Dr. Reagan said in our conversation with Dr. Hosford is, he said, you know, the pace of oncology is so different than the pace of OB, immediately postpartum care. So we have a girl who's just delivered and she's bleeding heavily, and it's an emergency. I mean, and we need a doctor at the bedside that moment, because it could be very critical. Whereas sometimes with oncology, and gen oncology specifically, that bleeding may be something that's expected, or you've seen it. I've heard Dr. Hosford say, I'm very comfortable with where her bleeding is right now. And when we're thinking of it in the scope of postpartum hemorrhage, it looks very different, and the pace of that is very different in the way that you respond to it. So anyway, just a few little tidbits there.
I guess my only concern is the family's perspective of what we're doing for their loved one. They feel whenever we're in those situations that we're not doing enough. And sometimes it's very difficult to get the residents to kind of come in and talk to these families. I don't know if they don't feel comfortable addressing the families as you feel comfortable, which you've had years of experience doing this. And sometimes I think it's their attitude when they come in as well to address the patients. They act hurried. They are kind of brash at times, not compassionate, not empathetic, and it's a problem. And then the patient's family and patient then take that out on us. We're the ones that get the brunt of that, and it's very difficult.
And the family has said, they're not listening to me. They're not hearing us. We've told them this and they're not hearing it.
Yeah, and sometimes it even reach a point, I don't want to talk to that doctor.
Yeah, that's happened.
Because it's not going to get us anywhere.
Well, so there's multiple issues. Sometimes what the family wants is not what we're going to do. And I've had to tell families and people in the office, you know, I know this is how you feel, but this is what I think. So you're going to get some run over to that, maybe even in a more acute setting because they're in the hospital. Each resident is their own person who brings their own skills and their own issues. They're probably scared shitless still working with me, okay? Because they're, the 4th-year residents now have just been exposed to working with a G1 oncologist one-on-one for 2 years of their training. So as the residents come up from there, they're going to have had the experience of having someone full-time here teaching, so they're going to be less nervous about the whole thing. They're going to be smarter going into it, because I lecture to them twice a month, about all these things, talk about expectations, not so much hospital stuff, but what cancer treatment is. So they're going to be smarter, less scared of everything, more comfortable with the disease state. But each person is their own, and you know, you're going to have some experience with them from the OB side, and they're not going to be any different people. Their strengths and the families aren't going to know them as well as they know me. I round on my patients twice a day, at least once, if not twice. They're seen twice a day by residents, and they're seen once a day at least by me. And not always when I come is the family there. So we're going to have, there's a disconnect. And these are almost all people, unless they were transferred in and it's my first time meeting them, people I've met in the office who've had surgery, who've had radiation, who've had chemotherapy. So it's not the first time that we're intersecting. And a lot of times if the family's not around, what happens is different people come at different times, and you've seen this before. And of course, it always comes out with acute stuff, is that there's 15 people that show up, they all know 15 different things, and they're all not all related in a way that they're going to know everything ongoing. So you're going to be getting the whole combination of those things. I struggle with that too, and I continue to try to make sure I talk to one or two people who are there most of the time, who then come to the clinic, and we can continue the intersection. If you're getting that message from the family that the residents aren't helpful, or they're saying things that it's not jiving, or that they say, I don't want to see that doctor again, then that would be an awesome opportunity to call me on my cell and say, this is what we're seeing. Because unless y'all tell me that, I can't figure out where's the breakdown happening. Do I need to support the resident more? Do I need to teach them something? Do I need to go with them? And I can't be everywhere all the time, okay? So there's lots of times where if you're seeing that, trying to identify what's triggering that, and then that would be an opportunity for all of us to go around and talk to the patient together, so that we then have our unified front. There are often lots of things going on under the surface about families, and cancer brings out the most complicated. Everybody and their mother who's somebody's cousin, girlfriend had breast cancer 10 years ago wants to talk about things. People get on the internet, find information that's helpful, sometimes not. So usually it's not the beginning of that. And at least the one young girl that died of cervix cancer recently, her family was very, very difficult from the very beginning to the very end. She was difficult in palliative care. They had a hard time. So sometimes it just is what it is. But for us to be unified amongst us, you, me, and the resident, and everybody's differences try to mesh, and then for us to communicate within ourselves so that we can communicate. And I continue to say the same thing to families. I continue to try to talk to the same people so that the message is true from what I say. Again, what they hear or what they want to hear, I can't control. So there's lots of levels. But if you're feeling that kind of thing, you need to let me know. If the resident is part of the reason there's some struggles, then you have to go and talk to me. You can call me, or you can tell Jill, hey, we need to, we're having some strife, why don't you call Dr. Hosford, and as long as the information's correct, we can talk about it. I think rounding, and I try to remember to do this and I'm forgetting, is where y'all come round with us, because that's when we're talking, the family that's there is there, everybody's hearing the same words, and therefore if they have different interpretations, you all at least know what was said. I am very straightforward with families. I am very truthful with families and patients. I tell people when I first meet them, particularly if they have a serious illness, I will always tell you the truth. If something's not working, I'm going to tell you. I will not mislead you. If there's a time to say we're not going to have any more treatment, I'm going to tell you. And even though that's scary for patients, it sets that tone that I'm going to be up front. I just recently had a lady who finished treatment, and she said that the first time she came in through the ER on a nighttime with ovarian cancer, she said, you told me what I needed to hear, you were straightforward, you didn't mislead me, and that was exactly what I needed to confront ovarian cancer. She's doing great, but she remembers that was the most important part. Of course, they were an easy family to deal with. And the people that are complicated, like everywhere, dysfunctional families, you know, and cancer brings out the most in it. So it is challenging, and I think the more we all band together and decide which couple family members seem to be the most reasonable, which ones can we communicate with, which ones can we continue to give information and encourage them to be talking to their families rather than getting involved with all 15 aunts and uncles who come in from South Texas. I mean, it's very, and then you say the same thing over and their perspective's different, and in the midst of the family member looking sick, and they haven't seen him in 8 months, and now they come in and they look horrible, and so it's kind of a gigantic storm. But I think if we all communicate, and you let me know if you're feeling something that you can't work out with a resident, because it's my job to make sure that they are compassionate physicians. Not everybody's as talented. They know different things. They have different perspectives themselves. They have people in their family that had cancer that they're all, this is a scary thing for them. But we need to address those things so that they hear the right message. They see us communicating, and that we all as a group can then deal with the families consistently and saying the same thing. Just like when you're raising your kids, same thing. You have to keep saying the same thing, and eventually they get it. But the residents are at different levels, and they're all like us. They're different skills, and they probably have no interest in being in oncology and want to get at it as fast as anybody else. So, but they have to do it as part of their training. Yeah.
So are we going to start keeping your patients until they pass, or are they going to?
Well, I'll let Jill address that, because we did have a conversation about the palliative care unit and what its design is for. I personally think if patients are comfortable and their needs are being met, the last thing I want to do is move them away from a place they're comfortable with. And a lot depends. We don't want people to die in the hospital. Sometimes they do, and sometimes they're dying acutely, and that's what they're there for. But my philosophy is that we should be able to manage them, because that's part of what I do. Well, Jill, why don't you?
So when we talked about this again with Dr. Reagan and just talked about the palliative care unit and what it's designed for, it's exactly what Dr. Hosford said, that the palliative care unit is not intended for people to die there. And that's another place that I think would be a great opportunity for all of us to tour through and kind of talk to some of their staff. And this in-service is the first in a series. We hope to have some of the palliative care nurses come and give a little bit of insight on comfort care and those kind of things. But the palliative care unit's goal is to get patients comfortable and to a point where they can be discharged. Nobody wants the patients to be dying in the hospital. And so in terms of, like, if we're going to talk specifics between the two patients that Dr. Hosford mentioned that we've lost in the last few months, the patient who passed on our unit and then the one who passed in palliative care. The difference between those two ladies and the reasons that the course happened differently was Miss Lopez was acutely dying, and at that point it was going to happen in a matter of hours, and transferring her at that time didn't make sense because she was actively dying, as opposed to the other patient who was able to go home and had to be readmitted and that type of thing. When she came back, it was appropriate for her to go to the palliative care unit because she was in the end of life phase but was not acutely dying. And so that's kind of where we've drawn that line of how to deal with that. I mean, ideally we won't deal with death often on our unit, but if there's a patient acutely dying and the transfer would be more traumatic than leaving them where they are, then we'll leave them there, and we'll call on those resources from the palliative care team who did come over and assist with that patient death. Yes, ma'am.
Another thing is, like, I feel like sometimes your patients are not that difficult, but there are some times that we're in the room constantly, and when we have really busy days, it's hard to be able to take care of our other patients and Dr. Hosford's patients.
And
like I said, sometimes we get really good patients from her, but there are some times that we're in there all the time.
And that whole scenario that you just painted is what our meeting next Wednesday, September 2nd, is to address. We are going to change the way that we're doing assignments for specifically Dr. Hosford's very sick patients, not necessarily the surgery patients and general gen, but the really sick patients, the really sick overflows. We are changing the way we're staffing, and so I encourage you to come to that meeting and we'll talk more in depth about that.
And then it's also an opportunity to identify what it is that's being so difficult. Is it because their pain's not being met? Is it because the family's anxious? Is it? So if we can identify what's getting you in there a lot, then if you talk to me, we'll say, is this solvable? The answer may be yes or no. If it is solvable, what can we do differently? Is it family anxiety? Is it patient anxiety? Is it really that they're facing the fact that their cancer's progressed and they're not dealing with it well? Some of those are manageable immediately, some of them are not. Remembering that the people in the hospital are going to be the sick ones, not the not sick ones. The GYN patients, I do a lot of laparoscopic surgery. Those people go home the same day. You don't even see them. The lady that spent the night last night did so because it was late and we needed to get an IVP today and it was easier. And the open cases, I try to get out of here by Friday, do their surgery on Wednesday, they're out by Friday afternoon. Those are general, like regular old hysterectomy people. The rest of the people in the hospital will be there because they're sick and they're needing something complicated, and it's not going to be the easy stuff. But if you guys are going in frequently, then I need to know what's going on. Miss Bennett's an example recently, who did great with her surgery yesterday, by the way. She needed every hour morphine. So after 12 hours of that, we started a PCA pump, even though she said to me, it was a lot better controlled when the nurse was coming in every hour. I said, but you really can push your own button. And she said, oh yeah, I guess so. If I push it, I'm, you know. So we transitioned from being in there, which was her comfort level, and she loved it, to identifying it after 12 hours that her needs are going to be met. And I said, the nurse can't come in here every hour on the hour and make sure you've got your morphine. Let's do it something differently. So if there are things that, and I do, believe me, I know, when y'all have a busy time, I don't like being pulled 5 different ways, and I know y'all don't either. But if you don't tell me or we establish how those things are going to go, we'll go through 3 or 4 of them, then all of a sudden it'll be easier because we will all know what's happening. So if that's going on, you can tell Jill, and she and I will communicate on, you know, we need to address it, because if we know it, we're going to be able to figure out what's going on. Sometimes it's solvable, sometimes it's not.
And sometimes it's, I mean, some of the things that are time consuming, some of them, I'm not trying to generalize it to all, but some of the things are just clinical comfort. And so that's why we've asked, not just in the interest of time, I do want to go ahead and move and let Veja kind of give her presentation on port management and then port maintenance, and then also let Allison do the PIC example. And I think that some of those things, when it's just every time that something comes up, you're having to pull the protocol and reteach yourself, or call rapid response, or call the PIC team, or call, you know, and all those things that are consuming a lot of time. But if you just felt more comfortable and had a little bit more training on it, then maybe some of it wouldn't be as time consuming. And again, you know, I know that kind of one of the general issues with time management in that case is that we have mom babies, and we're putting a lot of expectations on y'all for baby friendly and, you know, and all of this. And it's like, yeah, who has time to go and breastfeed with a mom for 30 minutes when, you know, we've got this next door? And again, that conversation, that whole setup is going to change. It's come from the Patient Quality Care Council. We've talked about it ad nauseum. You know, this is the reality of the patients that we have and where we are, and so we're going to make it better. So I encourage y'all to come to that. Before Veja gets started, any last questions or burning concerns for Dr. Hosford?
I would like to say one request. I would like to institute a policy that if you guys call the rapid response team for something other than trying an IV or something just technical, that means we have to call our resident as well. Because what I don't like is to hear the rapid response is there, they want to initiate some sepsis protocol, and I said, oh, wait a minute, I didn't know something was happening. In the middle of the night, I am so reachable, and if our resident's not reachable, you need to call me immediately, because I will get on their case. But the rapid response thing is kind of a trigger for something's happening. So can we institute that?
Sure.
You can call them first, but the second phone call is to the resident, and if they don't answer back in 5 minutes, tell somebody, please call Dr. Hosford immediately, because that will alleviate a lot of stuff that's happening that will be a lot of just educational and stuff, but I don't like not knowing that people are sick. And I had that thought this week. That's a good trigger.
And I think that's true for all, for all patients. OB patients, overflow patients, if we're calling rapid response for a medical concern, then the physician, the primary physician, needs to be notified as well.
Okay.
All
Anybody
right.
else we didn't get to? I know Veja's got her stuff and smiling faces. Okay, I promise I commit to being less scary and nicer. And I really am reachable at any time. You can text me as long as you tell me who you are on the text, because then I don't know a number, or call me.
And if you're using Cortex.
Oh, yeah, that's right. Or you can just say, I need to talk to you. So you don't have to say, yeah, the thing is, we're reachable. Residents need to be responsible. Thank you very much, Julie. Okay, good.
Thanks, Dr. Hosford. Okay.
Okay, I'm gonna get started, so.
Okay, girlies. Okay. It's like my kids. Did y'all hear that? It just came out.
That shouldn't be on film.
I'll delete that
We
part.
all use Cortex. Every day. If y'all can't get a hold of Dr. Hosford, you can always call the Cancer Center. She may be in clinic. And she spends a lot of time with her patients. And, you know, I know she's scary. She was really scary at first to a lot of us as well. So, I mean, I feel your pain, really, I do. And I want to be empathetic to the fact that these are different patients that y'all are taking care of too. So, if I can be a resource, please call. I'm happy to help. I want, you know, I'm proud of nursing, and I want y'all to be proud of what you do and to make the best decision and feel good about it. So that's important to me as well. Okay, this is a man, can you tell? So I just want to say a little thing about actually the port. So I don't know how many of you know, so I don't want to embarrass or anyone about whether you know about a port or not. So I'm just going to be very basic, okay? Because I don't know anything about birthing a baby. So please know that this is not something that I would expect that y'all would know, okay? So the port is actually, it's a silicone ball, essentially, in a metal backing, okay? So I brought a couple samples that I can kind of pass around, okay? Allison can pass one around, and then I'll start one in the back. How's that? So there's one.
So you're talking about a mic port.
There, say again. An omega port, right. I thought you said an omega port, which is completely different. But these are all similar terminology. The omega port was actually, when it came out, it was silicone all the way around. Joyce, do you remember that? The bottom port Joyce and I worked together on 4 East probably 24 years ago, maybe?
We were young, we looked good.
Yeah.
You still look good.
We're not even young then, Joyce.
So actually the omega port though was a silicone all the way around. It didn't have the metal sides. And we actually didn't like it. I didn't like it, did you? Because you could technically go through the side and go all the way through the silicone and back out. So that wasn't the best port to use. And I haven't seen an actual omega port in a long time, but that is a similar, I mean, really, well, we just call them a port because now there's a pulse port, there's a lot of different terminology that you're going to hear, and a company will say that this is a certain kind of port. Just know it's a port, okay? And a port will have the bottom, and so when you're accessing the port, you should feel in a stop, okay? Because you've probably hit the bottom. Now, one thing to know is sometimes when you hit the bottom, you probably need to come back just a little bit. Because just like any other IV, it could be a little bit positional because you've got the tip of the needle at the bottom. Does that make sense? And the other thing to remember too is while you're looking at that, this isn't very big, is it? So your bigger women, it's a little bit more difficult. And a lot of times what we have to do is actually hold it and press down. Okay? So that you can just secure the port between your fingers, okay? So it goes into the subclavian vein, as you see. Everybody see that? Where it where it goes to. Now, do you see it secured to anything? It's really not. It really is like this in the person, okay? And so sometimes, depending upon the way the patient lays or sleeps, it can actually flip, okay? So sometimes you might feel the side of the port, okay? So, but please, if you're in doubt, just call. We'll be happy to come and help you because we've had many of those different type of situations and we can, easily walk you through it, okay? So, accessing the port isn't really as difficult as it sounds. You're going to use your kit and you're going to maintain sterile technique, okay? So that means the mask that's in here for you, is for you, okay? We've had people who say, oh, well, I'm putting the chloroprep, so I'm sterilizing it. No, you got to wear a mask, and especially on these patients, because if they have had chemo or radiation already, they're probably neutropenic, so they're, very vulnerable to infection. So please make sure you're wearing a mask, okay, and that you're using sterile technique. Now, all of your patients here should have the bio patch. Everybody know what I'm talking about? Okay, all right. So that's the kit you should use. And if you get a patient who comes from the cancer center or anywhere else that doesn't have the bio patch on there, the reason is probably because, like in the cancer center, we don't, if the patient's coming in for just an appointment with Dr. Hosford and we're drawing blood, we will not put the bio patch because we don't think they're staying. So we've made up another little kit of our own just for cost savings purposes because we don't use everything in here. So the patient might not have a bio patch. I just want you to know that so that you're not surprised and think, oh, why did this patient come without one? You really just need to redress the port. A lot of times before we send the patient up, we'll do it ourselves, but I just wanted you to know that up front, that we just use the sterile gloves if we're just drawing blood and accessing the port. And a lot of times she wants to keep it until she's done seeing the patient, okay? So this is a port needle. I'll send a couple around. It comes in 2 sizes, but I also want you to know that, and this is not to scare you, but it does also come in a 1.5-inch needle that they keep in the
Will you pass the kit around too, so we can just see what it's called when we're
Oh, yeah,
looking
sure.
for it?
Here you go.
Is it a central line?
Could we turn it on?
Central line dressing just
Change.
changed.
It's the same as the central
Central line dressing.
Okay.
Do y'all want me to go through the content of the central line kit? I mean, I'm happy to if y'all are uncomfortable with
No,
it.
that's okay.
No? Okay, all right. So, the 1.5-inch needle, though, I do want to tell you is, they do have it available in central stores, and they won't stock it on your floor or anything. So you just have to call down there and tell them. And there's been some times that we've called and they said, well, we don't have any because it's not used very often. So if that happens to you, they do have it, they just can't find it, or the person who's working isn't finding it. So call the Cancer Center or call 4 East. Either one of them, we've used the needle. It's 1.5-inch.
How do you know which needle to use on?
Well, we customarily use the 3/4-inch needle, okay? So, I mean, I can't see anybody in here that would probably use a 1-inch needle on. And then you have to base it on the size of the patient and where exactly the port sits, okay? So if the port, I mean, you're gonna see all different types of ports as far as the height of them, okay? And the thinner the patient, the more, I would call it exposed, but it's not exposed to, it's still under the skin. But you're gonna see a lot of times where the port, is there one in, do y'all have a?
The port.
Port back.
Bring the port back.
So, a lot of times it'll be like this. You'll see that, especially on your thinner patients, okay? You don't need a a bigger needle for that. So the 3/4 inch is probably gonna, yes. Okay, if it's like this and it's flush against the skin, like this, so you can still use 3/4, right? So the only time we use the inch is when you actually have to push down to really feel it, okay? And when I was saying you need to grab it and hold it on the sides, to make you feel more secure, that's reasonable, okay? So, assess first without your gloves on so that you know exactly what size needle you're going to use, okay? And then the 1.5 inch needle, like I said, is for somebody that's really a lot deeper, okay? So, is that, everybody okay with that? Okay, and I just sent the needle around. So using your sterile technique, and I want to tell you that this is actually going to change for the Cancer Center too, over the last year, is that the sterile syringe, this is a sterile syringe, it is very different than these syringes, okay? And so I bet you all of you thought that this was a sterile syringe.
It doesn't say sterile on it.
No.
It says not sterile.
I mean, we did the same thing in the Cancer Center. We're like, it's wrapped. It's gotta be sterile. And so when we were getting our kits ready, when you're getting your kit ready and you open up your dressing kit, we were taking this, opening it, and putting it on our tray, but it's not sterile. So the initial syringe should be the sterile syringe. Once you've accessed the port and you've confirmed that you have blood return, okay, and that you're flushing easily, you can always go right to your non-sterile, okay, and then your heparin, okay? Y'all carry the heparin syringes?
Yes,
as well?
we do. They are stocked in, yes, they are. They're in all 3 Pyxuses. We had them put in there 2 weeks ago. All 3.
All 3. Okay.
There's
Okay.
more in, I'll have to look back. One of them has 5, the rest of them have 10.
When you're accessing a port and, or say you guys are changing the needle and the patient has had continuous fluids, you will not need to use the heparin. The heparin only needs to be used once you are either discharging the patient and you're removing the needle, or if the patient isn't getting fluids but they have the needle in and you just drew blood, so the last thing you would do would be heparinize it, okay? So the heparin sits in the bottom of the port, and that's what keeps it from clotting, okay? So what that means is when you're going to draw labs on the patient, once you access the patient, you are going to have to pull back and waste at least 5 mils, okay? So what I usually do, you don't have to do it my way, it's just the way I've done it, and I've learned it. I probably learned it from Joyce. But your sterile syringe, I always, once you have the port accessed, you'll inject, and I usually use like 5, and if it feels like it's injecting well, then I pull back. If I have a blood return, I just keep pulling back till I have my syringe filled, and then I discard it, okay? And then you can always easily put your maladapter, or your the female and the male blood, you know what I'm talking about. I can't think of the term right now. And to draw the blood out of the port. It should easily just come right out, okay?
Is that what you're talking about? The hub.
And then you'll then inject with regular normal saline, this one, and follow with your heparin. Okay?
How often do you need to do the heparin?
Only if you're,
I mean, if it's not got fluids and stuff going in it, like, do you need to do it like once a shift?
no,
What?
no, only if you're gonna access the port,
Only if you access the port?
yes. Or, no, I'm sorry, only if you're gonna draw blood or use the port, okay?
And then when you disconnect it
And then
from
when you
everything.
discontinue.
And when you discontinue.
Do you use the entire heparin?
I do.
Yeah.
Okay.
Okay, and just to confirm, so you know, for the Pyxus machines, FCU 1 and 2 have 10 flushes each, and FCU 3 has 5 flushes. That's where we're at. That's our par level.
Okay? What other questions?
That's more information than we've had ever. I feel like I'm in the know.
Well, you know, you're going to be nervous when you access for the first couple of times, and that's normal. I mean, even when I have to do a PD patient, I still get nervous about it, you know, because you want to maintain sterile technique, but you want to access it right the first time, and you know, to alleviate any pain to the patient. So, you know, I understand if y'all are a little nervous about it, and that's why I invite you. You know, just take an hour. You can come either to triage or chemotherapy. We're happy to have y'all anytime. We have the staff from MICU frequently has to give chemo because of chemo lysis or tumor lysis. So, but they're not normally doing that, and so they have to come down and do 5 hours. You know, once a year. We have them. We're happy to have any of you. If it makes you feel better, okay? If y'all want to come practice, if you'll bring that other port up, you can bring those needles and just kind of feel, you know, feel it over the skin. If that makes you feel better, please come up and help yourselves. I brought supplies to help us, and there's a lot of other central lines here, but you know, we very rarely use anything other than a pick or a board.
My patient coming in.
Okay. I guess one other thing is if you have a patient who comes in with a fever and they have a port, okay?
I'll be right there.
One of the first things you should think is maybe that they might have sepsis, okay? So don't forget about that in the port. It happens, not frequently, but it does happen. You know, the patient gets neutropenic.
So do you still access it?
Yes, and what you need to do is draw blood culture from the port and then one peripherally, okay? And so if you get something back from the port, you're going to know that it's the port. Okay? These can stay in patients a very, very long time. Very, very long time. And you may see patients with one in their arm. That's not unusual. Okay? And you access that the exact same way. Okay? The arms are actually easier because it's, you know, a lot more visible. It usually sticks up because you have a lot less skin. Okay?
Any rules about who can access?
It has to be an RN.
Okay.
Has to be an RN. Okay?
Can you show?
Oh, sure. So after I've done my sterile technique, okay, I'm just going to feel, and it's just very easy, straight in, just like that.
Just straight.
Just straight in. No angles, okay, straight in, okay? And so I can feel it hit the bottom. I can't go anywhere, right? Okay? And so that's when I'm going to check and make sure I have blood draw, okay? I'm able to aspirate blood. And if I'm not, but I can flush, you might just want to pull back just a tiny bit. Because like I said, if you're close to the side, you know, and your needle is hitting right against there, you're not going to get very good blood return. Okay, so just pull back just a tiny bit, okay? Then aspirate again, make sure you have blood, okay, and then you can flush easily.
So you just clean it with the ChloraPrep and then stick the needle in there? Is that it?
That's it.
Okay.
Do you
And then
prime that
flush
tubing
with the sterile.
first?
Yes,
Or
I
do you,
do.
okay,
Yes,
and
I
then you
do.
just draw back blood?
Mhm.
Okay.
So once you've got your gloves on and you've got your equipment already here, I always take my sterile syringe because I'm sterile, right? And I flush my needle, okay? And you're still sterile. Everything's sterile, right? And then you can just go and access. Okay? So what would happen though if I missed it?
You pull it out and get another one?
No, you can actually use the same
You
one.
can? Okay.
You can actually use the same one, okay? Because you're still sterile, okay? But you wouldn't be able to hit anything, right? You wouldn't hit a bottom. So you'd just go, you'd keep going, right? So if this is the skin and there's no port, okay, you would just go and you wouldn't feel a bottom. That's why I really want y'all to practice, because once you hit the bottom and you know, you're gonna know. And so once you don't, then you're gonna know you're not there, right?
Are you gonna reuse, what I mean is, if you stick it and you did not,
Yeah, you can use the
you have
same
to use
needle.
another one?
No, you can use the same
Use
needle.
the same.
Okay.
You can use the same needle. Okay?
Now, does she have to write an order every time the patient comes in for us to access the port?
No,
No?
no, you don't have to. There doesn't have to be an order. It's just like having an IV. So if if Dr. Hosford were to order, normal saline, maybe she's going to give a bolus and she wants to give 300. She's not going to say access to the port. You just know that that's the patient's access is their port.
Okay.
Okay?
Because we have some patients that tells us that you don't access my port.
You know why they're telling you that? Because they're told that. They're told that when the port is put in by the surgeon, make sure when you go to the emergency room that they don't access your port. Because you have to know what you're doing.
Right.
So the patient's going to tell you the same thing, because this has been, So what you have to tell them is, we've been trained in how to access the port. Okay? Now, if you're going to just draw blood, a lot of times the patient will say, I'd rather you just draw it peripherally. But just remember, the majority of patients who have a port is because they don't have any veins, okay?
Right.
Or the chemotherapy you're giving them is a vesicant, okay? So it's always safer to have a port anyway, and it's easier for them, okay?
And how long can that needle stay in that
7
patient?
days.
7 days.
And then you'd have to change the needle.
And then the dressing has to be changed like an IV? Or is it
Yes.
7 days as well?
It's 7 days.
With the bottle patch?
Yeah, I think so. I'm pretty sure.
We'll check the policy on that, but I think that's.
I think it's 7
But the
days.
needle is only good for
Yes.
The bile patch, anyway.
So when you
It's the
put
home
your,
dressing, you're
when
not-
you put your dressing on and you put your date and time,
Mhm.
it would make sense for the dressing and the needle to be the same, because then
That's
you
right.
would know when to change the dressing and the needle.
That's correct.
If not, you'd have to have two different
Yeah.
to know when
And we
the
might pull it
needle
out
is
on
new
accident.
and the dressing is new.
That's correct.
Why don't y'all come up and try the needle? Come up and just feel it. Maybe a row at a time or something. Or whatever. Y'all are grown ups.
Okay, so we're going to do just a quick in-service on the PICC line, and I know this is not going to cover everything, and some of you even asked questions this morning in the in-service about it, and I will get those answers to you. This is more about the situations like that we had last week, where I believe we had 3 PICC lines get clotted off, and we had to call the PICC nurse to come and do the TPA administration, and so I'm going to do an in-service on that. That way we can take over that process. First of all, ideally, we would love to not have to order that and use it. So one trick that I emailed out about last week was, if you go in, I'll just pretend this is a flush. So if you go in and you need to flush one of the lumen, this is a triple, and they come in all different shapes and sizes, which I did not learn until yesterday. There's 5 different ones. So let's just say we're going to use the white lumen. And I go to flush and it won't flush, and I'm pushing and I can't draw back and it won't go in. So what I witnessed the PICC nurse do last week was to have the patient extend her arm all the way out to the side. And once she did that, just with a little bit of pressure, it flushed. So I think having the arm straightened out can unkink, which obviously this is pretend, but it can unkink it from maybe where it got tangled up in the arm. If you try this and it still doesn't work, then we probably need to go to the TPA method. And I would recommend trying this first before you order the TPA, because last week on one of the patients, when she did this, we had to waste the TPA. And so if you try this first before ordering. So, okay, so let's say that did not work, and we're gonna order our TPA. It's gonna come tubed to you from the pharmacy. You do have to have an order for it. It comes in 2 meals. And that's all they'll send us, 2 meals, and it comes frozen, or at least that's how it's stored. So the one that I saw last week, it was icy in there, and then all she did was just hold it under her arm to help it thaw off. And if it comes and it's not cloudy, you can go ahead and use it. And of course it'll have a cap. Ideally, we would like to be able, again, to go in, clean our lumen, hook your TPA up, and be able to push a little bit of it into the line and let it sit. And that's kind of our intent, is to help it dissolve the clot. I will tell you that all of this information can be found on policy MA 294.0, and that's a medication administration policy found under the green forms on the intranet. And it even has pictures, and it tells you how long to leave the TPA before you can come back and draw. And it shows pictures of how to hook up the stopcock and everything like that. So if you come in and you absolutely cannot flush the TPA at all, you are going to have to use the stopcock method. If you were able to flush some TPA, you leave it in there for 30 minutes, and then you come back and you see if you get blood return and if it flushes easy, and then you would draw back 5 mils, waste that, and then flush with 20 mils of normal saline, okay? So of course, let's say this did not work. Here is what the 4-way stopcock looks like. I have seen actually 2 different ones of this, and we will make sure to get some of these ordered. This one, all of these short spaces here are open lines, and this one says off. The one that I watched the procedure done on last week, the off one did not have one, but all 3 of the open ones had one. So just make sure that you get familiar with it before you put it on the patient, okay? So we're going to use this, and I didn't bring the package, but again, we'll make sure to get some of these. We're going to hook on just like we would IV tubing or anything like that. Okay, so here we have our stopcock hooked up. The TPA is going to go in the middle one. 2 mils. And then you're just going to have an empty syringe that's going to go in this one, okay? What you're going to do is we're going to kind of create a vacuum in here that will hopefully help create negative pressure to suck in the TPA. So you want to make sure on this first draw that the off is to the TPA and that we have open coming from the lumen. This one doesn't matter, there's nothing coming out, but that we have open to the air. You're going to pull back and draw 9 to 10 mils of air and hold it because that's a negative pressure. And then you're going to turn it off to the air and it should suck in the TPA. I'm sure because we don't have it hooked up, but you can see this was set on 2 mils and it sucked in 1, even just having nothing created. So it does create a negative pressure, okay? If you can't get it on the first time, you can try a couple of times. Well, ultimately, we want all 2 to go in, but if it won't, just because of how clotted the line is, you can do this a couple times, or that may be enough. So you can just leave all this hooked up to the patient for 30 minutes, then come and check it, see if you can, see if you can get flush or blood return, and if you can't, you can do this process all again. If you do get some blood return and are able to push, same as before, you're going to draw back the 5 mils and waste that, and then you're going to flush with 20 mils of normal saline. One thing I just want to reiterate, and it was on my email last week, whichever one of these lines you choose to run TPN in, if the patient has TPN, that one needs to always be designated to the TPN. We don't want any reactions happening in that could clot off that one. And then you, of course, want to flush between bags if they're going to run immediately after each other, or flush after one finishes with 20 mils, and then flush again with 20 mils before you hook up the next bag if it's going to be a while in between them. The last thing that the PICC nurses wanted us to know is you can never flush the PICC line too much. You should just flush maybe every couple hours just when you go in there, just with normal saline. You do have to have an order if they want to do a hep lock or use heparin to flush the PICC line. But if we're just going in and flushing with normal saline, you can do it as often as you need to, and that should help them from getting clotted off. So hope that helps.